Hello, everyone. As you are entering the room, welcome. And do be sure to enter in your name and your organization in the chat. We just want to see who's here with us today. We are going to be getting started at the top of the hour. So, again, as you're coming into the room, feel free to enter your name and organization in the chat. All right, it's 2 o'clock. On behalf of the American Cancer Society and the National HPV Vaccination Roundtable, thank you all for joining us today for Session 1, 20 Years of HPV Vaccination Safety and Impact. As you are entering the room, please enter your name and organization in the chat. Next slide. Now, my name is Brianna Sally. I'm a program manager of knowledge translation here with the American Cancer Society and the organizer of this learning community. For those that may be new to this space, this series is being held in partnership with the National HPV Vaccination Roundtable to convene healthcare practitioners and public health professionals to share promising practices to protect adolescents against HPV and related cancers. We appreciate each of you for being here with us today. Next slide. Now, just to lay some expectations for housekeeping, please know that this meeting is being recorded. The slide deck and recording will be shared in a follow-up email after the meeting. Please keep your microphones muted during the upcoming presentation. You are more than welcome to add any questions that you may have to the Q&A box, as we will be pulling questions from the audience during our Q&A segment today. The chat box has also been enabled, so if you would like to comment on any of the presentations along the way, please feel free to do so. And lastly, closed captioning is available. Next slide. Now, today's presentation and agenda is as follows. After today's welcome, Dr. Erica Thompson with the University of Texas Health San Antonio will kick off our session with a dive into the history, safety, and efficacy of the HPV vaccine with the science that saves. Following Dr. Stuart Lyman with the Head and Neck Cancer Alliance will share his survivor story before Dr. Anu Agrawal walks us through some helpful strategies and current info to support frontline staff in the HPV vaccination advocacy. We look forward to engaging with you as our audience in our live Q&A at the end of the session before closing out for the day with some resources and more to come. Next slide. This session will cover the following learning objectives, discuss how to implement evidence-based strategies for on-time vaccination, effective provider-patient communication, approaches to vaccine hesitancy, quality improvement, and cervical cancer elimination. And then summarize how to address barriers to HPV vaccination, including parental vaccine hesitancy, concerns about the efficacy and safety, and clinical workflows. Next slide. Now, as a reminder, this session is eligible for one live CME Senior CE credit. Details on how to earn credit can be found in the CME CME or CNE document in the chat. And it was also shared in our reminder before this session. Now, as a live participant, you must complete the Survey Monkey evaluation shared at the end of the session to receive that credit. So please be sure to stay on to the very last slide after the thank you slide to get access to this evaluation, as it will not be shared in the follow-up email. Next slide. But first, please participate in our pre-session poll, test your knowledge, and let us know what is the most important factor in encouraging on-time HPV vaccination. Let us know what you think. Oh, we're off to a strong start already. So far, it looks like about 70 or so percent is saying a strong provider recommendation. About 25% is saying starting at age 9. I'll give it a little bit more time, as I know we only have about 76% of people in our audience today who have responded. So if you haven't yet responded to the poll, do be sure to drop that answer in. And I see this number climbing. So for those of you who are recently entering the room, test your knowledge by responding to the poll. What is the most important factor in encouraging on-time HPV vaccination? Let us know. All right, Miss Katie, we'll go ahead and close out that poll. Feel free to share those results. And it looks like the majority of us said a strong provider recommendation. So we'll see. Stay tuned. We are going to go to our next slide where we are going to jump into this amazing content that we have prepared for you today. We'll begin with Dr. Erica Thompson, an associate professor with UT Health San Antonio. She has informed us of disclosures receiving funds through the university for independent research and research consultation for Merck related to HPV vaccination. Please feel free to add any questions that you may have for Dr. Thompson to the Q&A box throughout her presentation. Take it away, Dr. Thompson.
Wonderful. Thank you so much. I'm delighted to be with you all today, and I'm looking forward to sharing with you an overview of HPV vaccination in the United States and to review the effectiveness and safety of HPV vaccination. Next slide, please. And maybe one back, sorry. But first, we need to take a look at the cancers that are caused by HPV to understand the scope of this public health issue. As many of us know, HPV causes 6 types of cancer, including cervical, which we think of as the tip of the iceberg because that's what we first saw the connection between HPV and cancer, as well as oropharyngeal, anal, penile, vaginal, and vulvar cancers. Collectively, there are about 39,300 cases per year caused by HPV, and luckily we have the opportunity to prevent most of these cases through HPV vaccination. Next slide, please. So we're going to take a journey back in time. It's 2006. Think about where you were at. I was starting my freshman year of college. You may have been using your flip phone, logging into Facebook for the first time, or playing on your Wii. And 20 years was a long time ago. Well, 20 years ago is also when the first HPV vaccine was approved. And I want to walk you through what this looks like in terms of our history of this vaccine. Next slide, please. All right, so all of the available prophylactic HPV vaccines that I'm talking about are made from virus-like particles that don't contain any viral DNA and are non-infectious and cannot cause actual disease or cancer. And as I move through this slide, you'll see at the top right part that the 3 vaccines that have been available in the types of HPV that these vaccines prevent. So this timeline walks us through the Advisory Committee on Immunization Practices in the U.S., which has traditionally set vaccination guidelines for the U.S., and more to come on that later. And while I'm starting in 2006, a lot of scientific advancements had to come into play in order to get us there. So in 2006, we first saw the recommendation for females with routine ages 11 to 12 and available ages 9 to 26, and the quadrivalent vaccine with 3 doses of this vaccine. And 3 years later, in 2009, we saw the expansion of a bivalent vaccine available for females for the prevention of type 16 and 18, and the first time for a male permissive recommendation for ages 9 to 26 with a quadrivalent vaccine. It wasn't until 2 years later that we saw the guidelines adjust more to include routine vaccination for males ages 11 to 12, permissible for ages 9 through 21, and then with 27 to 26 having a recommendation for men who have sex with men with a 3-dose series. In 2015, The nonavalent vaccine was recommended with the protection against 5 additional strains of HPV for males and females, and that's what we see on the market today. And in 2016, the next year, there was a change in the dosing schedule where we had a 2-dose option for ages 9 to 14. And then where we're at today, the last update was in 2019 for ACIP guidelines with the age harmonization of the upper age limit of 20 up to age 26 for males and females, and the inclusion of shared clinical decision making for 27 to 55. So that's a lot. Today, again, we're using the 9-valent vaccine predominantly, and adolescents ages 9 to 12 should routinely get the HPV vaccine with catch up until age 26. And shared clinical decision making is the recommendation for those 27 to 45-year-olds previously unvaccinated. So as you can see, there's been a lot of twists and turns, but this has to do with the evidence and scientific evidence evolving over time. So next, please. And we know from an accumulation of evidence over this 20-year period that HPV vaccination works. And we've already seen the life-saving effects of this vaccine. So next slide, please. As a result from US studies, this has indicated we've seen an 88% decline in HPV type prevalence among females compared to earlier years, a decline in the incidence of cervical precancers, as well as a decline in the rates of cervical cancer. Other countries are already seeing this dramatic decline in cervical cancer as well, and this is to do with high HPV vaccination rates in those countries. Next slide, please. In addition to the evidence showing a decrease in cervical cancer, we have solid research on HPV preventing HPV infections of the head and neck or the oropharyngeal region. In fact, one study of US men found that those who reported vaccination had an 88% lower rate of oral HPV infections. This was one of the reasons that in 2020, the FDA added oropharyngeal cancer as part of the indication for the vaccine. And there are more studies ongoing to show the efficacy of HPV vaccination for oropharyngeal cancer prevention. Next slide, please. And beyond cancer, we have other HPV vaccination outcomes, such as a decrease in the prevalence of anogenital warts, as well as declines in juvenile onset recurrent respiratory papillomatosis. Next slide, please. So to close out our discussion on effectiveness, and that is just a brief overview, I really want to emphasize that protection lasts. Data from clinical trials continue to show that HPV vaccination provides long-lasting protection.
Dr. Thompson, I just want to let you know some of our audience members are having a hard time hearing you.
Oh,
I
so sorry.
I can't tell if it's just the volume or maybe something going on with their interface, but just wanted to let you know.
Thank you. Is this any better?
It sounds better for me. If anyone
Okay.
in our audience
Okay.
can give us a thumbs up or something, that would be great.
Apologies about that.
Okay,
Sorry.
thank you.
Zoom gives me trouble some days. So sorry about that. So
Sorry.
and thanks for going over. We've gone over the effectiveness of this vaccine, and now just to transition into the safety of this vaccine. So next slide, please. All right, so let's shift gears a little bit. And next slide. We see there's a lot of evidence in terms of the safety of these vaccines. It's one of the most studied and safest medications available. Each of the HPV vaccines were once available. The 9-valent, quadrivalent, and bivalent HPV vaccines went through strict safety testing before our Food and Drug Administration licensed it. And each vaccine was found to be safe and effective in those clinical trials. Additionally, you should feel confident that the U.S. has a very robust monitoring system, which we'll touch on briefly on the next slide. And there's more than 15 years worth of safety data. Additionally, there's been over 135 million doses of HPV in the U.S., HPV vaccine in the U.S., and 500 million worldwide. And that number increases every day with more adolescents getting vaccinated. Next slide, please. And this slide just briefly touches on our systems we have in place in the US to review safety, including spontaneous reports, active surveillance, and epidemiological studies. So HPV vaccination is included in these systems. Next slide. So we went through a lot in a short period of time. And we've gone through the timeline from 2006, where we started with HPV vaccine recommendations and establishing the effectiveness and safety. And today we're in 2006 or 2026, excuse me. You might be using your smartphone, which is so different than the flip phone, although I know some people are using that again. People may be on TikTok or other social media platforms that I have no idea about, and then using their Switch instead of their Wii. Times have changed, and reflecting back on where we've been and where we're at today, it's amazing to see that we have this safe and effective vaccine available to prevent 6 cancers. And I'm looking forward to seeing the evidence generated moving forward. And next slide. And I'd be remiss if I didn't briefly touch on changes in vaccination guidelines that are currently ongoing. So I went through the history of the Advisory Committee on Immunization Practices guidelines for HPV vaccination. And we know that the composition and practices of that committee have shifted dramatically in this last year. But historically, ACIP uses what's called as grade methods or grading of recommendations, assessment, development, and evaluation and evidence tables to make these standardized recommendations for transparency, consistency, and weighing the benefits and harms, the values and preferences, and health economic analyses. In contrast, our most recent childhood vaccination recommendation changes from the U.S. Department of Health and Human Services on January 5th, 2026 was a summary of recommendations based off comparisons to peer nations. And in this document, HHS recommended including, it still included HPV vaccination, but as a single dose. And we saw other changes for what were routine childhood vaccinations. And so while we see that these recommendations have come down from the federal government through HHS, it doesn't necessarily follow the same historical processes we've used in terms of evidence reviews. Because of that, many organizations, including American Cancer Society and American Academy of Pediatrics, have reaffirmed guidelines from prior guidelines from ACIP and following those immunization schedules rather than the revised schedule made as of January 5th. I think this underscores that this is a confusing time in terms of vaccination, including HPV vaccination, which can put us at risk of backsliding from the considerable progress we've made in terms of vaccine effectiveness. And again, many organizations are pointing to AAP or other groups who are coming up with recommendations that mirror our historical standards for evidence. And on my last slide, on the next slide, this leads me to where we're at today. And as of data from 2024 NIS teen, approximately 78% of adolescents had at least one dose of the vaccine and 63% were up to date on their series. We still have a ways to go to get to our goal of 80% up to date status, but I don't want to discount the progress we've made. HPV vaccination is safe and effective, and we need to continue to innovate and collaborate to increase vaccination rates to prevent HPV cancers. Thank you.
Thank you so much for your presentation, Dr. Thompson. Your presentation, for me at least, really helped instill a lot of confidence in HPV vaccination safety, and hopefully for our audience as well. I appreciate you. Up next, we have Dr. Stuart Lyman, who is a retired cancer researcher and an HPV-attributed tonsil cancer survivor. He has disclosed that he has previously received an honoraria from ELSA and Merck related to HPV vaccination. Please feel free to add any questions that you may have for Dr. Lyman to the Q&A box throughout his presentation. Take it away, Dr. Lyman.
Thank you very much. I appreciate the opportunity to share my story with you today. I'll be speaking on behalf of the Head and Neck Cancer Alliance, which is a wonderful organization that, if we can go to the next slide, part of their mission is to provide hope and support to individuals who have been impacted by head and neck cancers, to raise awareness about prevention and early detection, and to advocate for improved patient outcomes. Next slide, please. So this is the take-home message, right? We all know this. Cancer prevention always beats cancer treatment. Now, the HPV vaccine was not available to me when I was a kid, and I greatly regret that because I did wind up developing an HPV tonsil cancer. And parents these days have a choice. They can get their kids the vaccine or put at risk their children for eventually sometime needing surgery, chemotherapy, or radiation to treat their HPV cancers. Now, most patients, I think, when they tell you their stories, will focus on how terrible treatment is and the horrors of surgery and chemotherapy and radiation, and those are all true. But I'm not going to focus on that. I'm going to take a little bit of a different tack today and talk about the psychological strain and problems that come from getting a cancer diagnosis. Next slide, please.
And Dr. Lyman, it looks like our audience is having a hard time hearing you as well. If you could just try to speak as loudly as you can just to make sure that they can hear you. Sorry to interrupt. Thank you.
Okay. So cancer patients and their tumors are like snowflakes. Despite similarities, no two are ever exactly the same. The story I'm going to tell you today is unique to me, but all cancer patients have their own unique stories. Next slide, please. Now, the psychological stress that cancer inflicts, it can cause as much misery as the physical pain that many of us endure from the various treatments. And in my case, this certainly turned out to be true. Next slide, please. So I'm going to tell you my story in 4 parts. In part 1, bad news delivered badly was how it all began. When I was 61 years old, I went in for my annual checkup, and my doctor said, okay, open your mouth and look in there. And he said, oh, something doesn't look good in the back there. Does that hurt? No, nothing in there hurts. He goes, well, I'll give you a 2-week course of antibiotics. We'll see if that takes care of it. And if not, we'll send you to see an ENT. It did nothing, so I did go to see the ENT. And that appointment with the ENT literally took about 4 minutes. I sat in the chair, the ENT came in, he said, open your mouth. He took a look inside, he said, it's cancer. I don't know what kind of cancer it is exactly, but it's cancer. And I'm going to go ahead and set you up an appointment with an oral cancer surgeon, and they can take out your tonsil and figure out what the next steps will be. And hearing that you have cancer is it just takes you to a very, very dark place. And for me, part of that involved thinking about my mom. Next slide, please. Now, why is my mom part of this story? Well, as it turns out, my mother was diagnosed with cancer at the exact same age I was. She was 61 years old. Different type of cancer, but exact same age. And in my mother's case, she was dead and buried less than 90 days later. And that thought weighed heavily on my mind when I received my cancer diagnosis, because I was married, had a wife at home, my son was in college, and I had a lot of things I still wanted to do in my life, and I was terrified by the thought if I could follow the same path as my mom. That was not going to be a good thing. Next slide, please. So let's go on to the next part. Now, it says here, I've already met the worst tonsil doctor in America. This time I need the best. Who would ever make a statement like that? Well, I did. And this is what I told the doctor. And this is why I told the doctor what I told him. Most of us never think about our tonsils, but in my case, I thought about it a lot. When I was 7 years old, my parents took me to the hospital to have my tonsils taken out, which was a common operation back in the early 60s. And unfortunately, the operation went horribly wrong. Somewhere in the beginning, either the doctor and or anesthesiologist wound up knocking out 4 of my teeth, one of which I inhaled, went into my right lung. And 2 weeks after this, I found myself in a major hospital in New York City having part of my lung removed to get that tooth out because back then, of course, they didn't have the fiber optic scopes that they would have used these days. And that really set me back in life in ways I don't have time to describe today. It was a very, very horrible experience. And as a result of that, now having been diagnosed with tonsil cancer, because of course the surgery was stopped when they knocked my teeth out, they never took out the tonsils. I thought, my goddamn tonsil is trying to kill me a second time. This is terrible. So I told the story to the tonsil doctor, that is the surgeon, and this time things went much better. Next slide, please. Here I am 2 days after my cancer surgery. You can see the slide labels me a lucky man. Why was I a lucky man? Next slide, please. Being diagnosed with head and neck cancer really sucked, but I'm fortunate my cancer was caught early. I only needed surgery, and the 5-year survival rates were greater than 90%. The recovery was difficult. I lost 50 pounds over that 6-month period, but I was really lucky because I avoided the chemotherapy and radiation that most patients get. I had robotic surgery instead, and I'm really grateful for that because those treatments are extremely debilitating. And I had insurance to cover most of my bills, which was also good because, of course, the financial toxicity associated with a cancer diagnosis can wipe out your retirement savings and leads many cancer patients to bankruptcy. Next slide, please. So as I recovered from my cancer surgery, I asked myself, what can I do to prevent others from going through what I and tens of thousands of other HPV cancer patients in the US have endured? And how can I convince parents to give their kids the HPV vaccine? Next slide, please. And I came up with 2 answers for that. One is to share my story, which is what I'm doing now, and the other is to educate people. Next slide, please. So I went ahead and I built the most comprehensive support educational website for patients, for parents, and physicians. Covers all aspects of HPV cancers and the HPV vaccine. It's called hpvcancerresources.org. There's over 175 detailed FAQs there, and I suggest all of you please check out the website. There's just a ton of information there, and all the different patients that I provide support to and help tell me it's invaluable on their own journeys with their own respective cancers. Next slide, please. But there's one more thing, music. So these days I also spend time as a songwriter, and I co-wrote a song with my friend Willie Laufer, who is also an HPV tonsil cancer survivor. Kind of describes what the journey is like. It's kind of a bit of a heartbreaking song to listen to, but I encourage you to look for it. It's the only song with this name, and you can find it on YouTube where you get to actually see the video, or you can stream it on Spotify, Apple Music, or whatever, your favorite source. So check out the song if you have a chance. Next slide, please. And I want to conclude today with the final part, which is to tell you on May 10th, which is just a couple of months from now, I'm going to become a 10-year cancer survivor. And that's a really good place to be. And it's much better sitting in that dark place I found myself in back in 2016. And I'm really grateful for all the support I've had from family and friends and for the great care I received from my medical team. And with that, I thank you very much, and I'll be happy to answer any questions.
Thank you, Dr. Lyman, for your presentation. And if you haven't tuned into the chat so far, there's a lot of love coming through, especially for this amazing celebratory anniversary that you're having right now. Congratulations to that. And thank you so much for just sharing your story with us, sharing your webpage, your musical contributions, and all the works. Your ongoing advocacy is very much appreciated and perfectly aligned with our upcoming presentation. So we're going to go ahead and go to the next slide. All right. So in our final presentation, we have Dr. Anu Argwal backing the front line with HPV vaccination advocacy. Can you go to the next slide for me? Thank you. Please feel free to add any questions that you may have for Dr. Agrawal to the Q&A box throughout his presentation. Take it away, Anu.
Thanks, Brianna. And yeah, really great to follow that presentation. Thank you, Dr. Lyman, for sharing the personal story. That's hopefully a lot of motivation for everyone to be advocates for the HPV vaccination. So my talk is kind of done already, but yeah, it's really my pleasure to, as a pediatrician first and a pediatric oncologist second, really present this part. So really the biggest thing to highlight in this discussion is that your recommendation as a provider matters. It still matters today, even with everything happening in the world and loss of trust. People do still trust their healthcare providers, and driving on-time vaccination, as mentioned in the first poll, the most important thing is that recommendation that we can all give and make sure that's a strong recommendation, that we really focus on one thing to keep it simple, and that the HPV vaccination is for cancer prevention. And that also we're trying to still complete the series. It's something that we can discuss in the Q&A. I saw that question that we still recommend as organizations, and I have some slides as well as the slides that Dr. Thompson shared about sharing the still supporting the multi-dose recommendation, and also making it routine. That I think the HPV vaccination has challenges because it's thought to be outside of the routine schedule. So as much as we can, as providers, include it as part of the routine vaccination schedule and how we talk about it, all those things help to make it something that families move from potentially hesitancy to acceptance. So again, this is just some data showing that by providing a strong recommendation, that you're much more likely to get patients and their families to vaccination. So this large analysis across multiple health settings showed almost a 10 times higher odds of vaccination when the parents received a strong recommendation. And then also strong recommendations lead to shorter conversations. So keeping it simple and being directive can help in many situations. And then we'll talk about what to do when there can be continued hesitancy, but that can really be helpful. And otherwise, the type of style that you have, none of that really needs to change. The length of the way you discuss things, you can keep the personal ways that you do that best. It's just really focused on making a strong recommendation and keeping it short. So this just highlights that as well. So without a recommendation, about half of patients were vaccinated. With the strong recommendation, that jumped up to 75%. So again, just to highlight that all of us as healthcare providers play an incredibly important role in getting patients and their families to vaccination. We're going to talk about potential barriers from the healthcare worker standpoint, and trying to overcome these barriers from our side, because again, the vast majority of families trust us, and so we need to overcome our own potential biases against the vaccine in order to make a strong recommendation. So these are some of the ones that came up in the literature. The age, too new, the potential linkage to sexuality, potentially increasing risk of risky sexual behavior, other barriers, overcoming parental hesitancy, cost, and lack of evidence for efficacy and safety. So we'll talk about those a little bit later. So I again wanted to just talk about the approach to how you recommend the vaccine. So generally the first line is just to make a strong recommendation through the announcement approach. So this is a routine vaccination. You're here today for a routine visit, and as part of that visit, you will receive these vaccinations. So it's just part of the standard of care. Destigmatize it. It's not something different than anything else you'd receive as part of your visit today. That can be very effective for a large number of families. It also helps if you have limited time. When you need to have more discussion, you move to motivational interviewing. So the flow chart here on the side shows that you start with a strong recommendation. If they're not hesitant, there's a yes, then you're done, you vaccinate. And then no, if there's some hesitation, then you move to motivational interviewing. So Really, the approach with motivational interviewing is to make the families, number one, feel heard, to really understand their perspective, make them feel like they're also part of the decision making, that you're not pressurizing them into a decision that they may agree with, trying to understand and explore why they have hesitancy and trying to answer their questions. And by doing that, you can actually move many families, not all, but many families from hesitancy to vaccination. But really, the key is to develop trust. Hopefully, these are patients and families that you've already been seeing, already trust you, trust your opinion, and that they're also open to discussion, recognizing that their sources of information may not be accurate, but to try to do that also in a non-judgmental way. And hopefully by erasing the myths, they'll move from hesitancy to acceptance. And I think we all know this, but vaccine hesitancy, really, the roots of it have come out of two things. Partly the medical establishment or the quote unquote medical establishment that's published papers that have subsequently been refuted that showed links to vaccination and autism. So that remains something that continually comes up due to a initially paper that was published in 1998 by Wakefield that's now been shown to be not true, but unfortunately still facing challenges because of that. And then the other piece of it is social media, where you're able to promote viewpoints that aren't true, but can get many, many followers. And so it is a challenge to ensure that the truth remains. But I think in general, healthcare providers are still seen as truth seekers and where truth can be had. And I think again, if you look at the continuum of vaccine acceptance here at the bottom, that there's going to be families that are in that far right corner that are going to refuse all vaccines. And aren't willing to have a discussion, even if you try motivational interviewing. And that's okay. I think that we have to accept that we're not going to get everybody to acceptance. But then those areas in the middle where many of those families, they trust you and you can get them to acceptance. And this is a US wide. This is a global of coming from the global side. This is a global problem, but it's a problem across the US. This isn't related to any particular zip codes. This is a problem in pockets throughout. So it's something that we're all going to see in our practice if we're doing primary care. So I just wanted to go through the myths a little bit because these are questions that I'm sure you all have had and will continue to have. So first and foremost, the HPV vaccination is not safe. So the facts are that now this is one of the most, if not the most, heavily studied vaccine. It's been on over the market over 20 years now, with over 500 million doses distributed and over 135 million doses distributed in the United States. So it can be said with 100% certainty that this is one of the most studied vaccines, medications on the market, that it is safe, just like any other vaccines given at this age. Some additional information about that, some specific questions that might come up. So you all may have heard things about aluminum in the news recently. So aluminum is very important to stimulate the immune system of the body against the antigens in the vaccine. So it's very safe to receive that, and it's much less the amount that we get in our daily utilization with food and cooking utensils. It does not have thimerosal. Can it lead to infertility? So there's no link to infertility from the HPV vaccination. And in fact, HPV diseases themselves can lead to problems with fertility. So the reality is actually the opposite, that the HPV vaccination can be protective of fertility. And then adolescents with complex medical conditions. So generally speaking, adolescents with complex medical conditions are more likely to have infection-related complications, and so they are at increased risk from not getting vaccinated. So again, counterintuitive to what might be stated, that the research shows that that group of adolescents is undervaccinated, though they are more likely to benefit from vaccine. So it's very important to get them vaccinated. Second, HPV vaccination is just for girls. So in a global setting, we do focus just on girls because this is a resource issue. In many low and middle income countries, there's not enough supply. And so we have to focus on the girls. Fortunately, in the US, as a high resource setting, we have enough vaccine for everybody. And so, as Dr. Lyman very well highlighted, HPV infections can lead to cancers in both men and women. So it's very important for both boys and girls to get vaccinated. So it's just a simple fact that yes, cervical cancer is the number one HPV related cancer, but HPV infections cause cancers in both men and women. Three, this comes up a lot, that somehow the HPV vaccination, by getting the HPV vaccination, promotes sexual activity in preteens and teens. So there's lots of research to show that getting vaccinated against HPV does not lead to increased sexual or earlier sexual activity. So again, the simple message is, and this is why we involve cancer organizations throughout the world, is that this isn't about sex or sexual transmission of the virus. The vast majority of people will get HPV virus without sexual activity. So it's really about cancer prevention. And so we have to always continue to focus on cancer prevention. I think the other differential challenge is that people see the infectious diseases, right? They see the potential immediate benefit, but this is a benefit that you see 20, 30, 40 years, 50 years down the road. So I think that's that time lag that people don't see. But as much as we focus on this is cancer prevention, wouldn't you want to do everything to protect your child from cancer? And those are true and key statements. People may bring up that since it's not required for school, it isn't needed. So not all recommended vaccines are required for school, but that doesn't decrease their importance. Um, so I think that's important to just hallmark that distinction that it is part of the routine vaccination schedule, and that although it's not a requirement, it's still strongly recommended. And that's highlighted by only 5 states require HPV vaccination. But that doesn't in any way mean that it's not recommended and strongly recommended to still receive. So we have lots of resources that are useful. So we have our ACS public health statement on the importance of vaccination. Also, just a reminder about the schedule. So for on time, 9 to 12, still recommend 2 doses, 6 to 12 months apart. For those that are a little bit late, 13 to 14, still recommended 2 doses, 6 months apart, 6 to 12 months apart. And then for those that are late, so 15 to 26, and not above 26, 3 doses. So the first dose at visit one, the second dose 1 to 2 months later, and the third dose six months after the first dose. And the reason for this is to promote long-term immunity. So younger, your immune system works better and you develop long-term immunity faster. Thus the need for less doses. And we can discuss this more in the Q&A because I think that we're in a challenging time where truth is hard to find sometimes, and you have now conflicting guidance, as noted. So we try our best to follow the recommendations that are recommended by multiple national medical societies, including the American Academy of Pediatrics, the American Academy of Pediatric Immunization Schedule, which still, of course, includes the 2 doses of HPV. There's also additional multiple statements from leading organizations, AMA, others, all regarding the potential change to 1 dose. Globally, we recommend 1 dose in low and middle income country settings, and this is largely based again on resources. So we're very fortunate that we have enough resources here to vaccinate both boys and girls and to recommend 2 doses. And similarly, insurance companies have similarly stated that they continue to plan to cover two doses of all ACIP recommended immunizations. And here's just some additional information. It was in the news recently, as most of you probably saw, wanting to change the immunization schedule to match with Denmark. But just clearly noting that the United States and Denmark are significantly different. The bottom right just shows, from a size standpoint, Denmark's about 8 million people, so which is the size of New York City. And we're a mixing pot, of course, the United States. We're significantly more heterogeneous as a population. And of course, we lack the safety net and the really benefit of having a national health system with significant amount of prenatal care and all of those different pieces. So um, yeah, it's very hard to compare the two countries and the vaccine schedules in those two places. And also, I think a lot of the data as shown in the bottom right can be misleading because the number of vaccine doses in the US is also largely based on yearly immunizations, such as against things like flu, which are not included in many countries like Denmark. And we'll be able to talk more about that in the Q&A for certain.
Oh,
Thank you.
thank you so much for this insight and your support of our healthcare workers and providers, Dr. Agrawal. Next, we are going to be going into our Q&A. We're going to invite all of our presenters back, and we're just going to unshare our screen briefly so we're all in the room together, just to see if you have any additional questions that you would like to address with our presenters today. Feel free to enter them into the Q&A box, and we'll go ahead and jump right in. So a question did come through from Ms. Blessing. This was directed at Dr. Thompson, but I know that your presentation also touched on this a lot anew. What are the implications of the HHS new rules, recommendations to HPV vaccination uptake and research with the conflicting recommendations? How do we move forward?
Well, I think Anu did a great job describing the other professional organizations and how those organizations are moving forward based off of the scientific evidence here in the United States. I think, though, in terms of a practice standpoint, it's going to create a lot of confusion moving forward. And also, we're seeing difficulties in the research space around vaccination research as well. So I think this has been an unprecedented year of just chaos and confusion around vaccines, and we're all having to react rapidly.
Right. What about you, Doctor? Knew anything you'd like to add?
Yeah, I mean, I think that again, making the strong recommendation that this is part of routine, and that just highlighting that the vast majority of vaccines are given as multi-doses, right? I mean, remembering back to when their child was a baby and received the 2, 4, 6 month vaccines, kind of maybe helps normalize two doses. Now that being said, if you can get them from 0 to 1, that's better than nothing. So I think also we just recognize that sometimes compromises have to be made, and you may not be able to get them from 0 to 2.
Right.
So one dose, and globally, again, it's largely a research issue. Globally, in low and middle income country settings, the World Health Organization has recommended one dose, and that's part of the reason the HHS moved to that recommendation. Again, not recognizing the difference between the United States and other settings, but I do think that you would get protection from one dose a lot more than 0, of course. So I think it's partly just what you can achieve. Um, but yeah, these are the challenges that we face, which is going to be vaccine hesitancy beyond just HPV.
Yeah, thank you. And I know that we are pretty limited on time for our Q&A segment, so I have one more question that I want all of you to answer if we could go around and do that. So we know that Healthy People 2030 has great aspirations of 80% vaccination completion for adolescents, while WHO and many other leading organizations have goals of cervical cancer elimination. So what gives you hope when you think about the next 20 years of the HPV vaccine and HPV cancer prevention? Who would like to start us off?
I'll jump in. I think what excites me and gives me hope is seeing these roundtables, coalitions at different state levels and regions coming together around concepts of uh, elimination, cervical cancer elimination, and hopefully one day HPV related cancer elimination. This is a health issue that requires a lot of sectors, a lot of different people to work together and collaboratively. So I just continue to be reassured by everyone coming together for that collective goal to reach those higher HPV vaccination rates and
Right.
still staying in the fight.
Absolutely. Stronger together.
I'm happy to go next. For me, just working in the global space, really see a lot of the positives. There are countries like Australia, which will is on track to eliminate cervical cancer, and elimination means less than 4 cases per 100,000 people, so it's not zero, but to eliminate cervical cancer by 2035, so which is an incredible landmark to achieve in other countries like
Absolutely.
Sweden and Denmark that are not far behind. So, and we're seeing more and more progress in low middle income countries as well. Rwanda is a really exemplar example of over 90% vaccination. So we're seeing more and more countries moving towards the WHO 2030 targets, as you mentioned, which is 90% of girls fully vaccinated but with the HPV vaccine by age 15. So, yeah, that gives me a lot of hope that we're continuing to see a positive momentum across the globe in various settings.
Absolutely. I love that. And bring us home, Dr. Lyman.
Well, for me, I think it's important that patients continue to share their stories because a lot of people don't still know that HPV can cause 6 different kinds of cancer. And I never get into these arguments with anti-vaccine people because there's nothing I'm going to say that's going to convince them. What I do is tell people about what it's like actually being a cancer patient
Right.
and how terrible it is to have to go through the surgery and the chemo and the radiation, and how patients who have head and neck cancers wind up with osteoradial necrosis and they have to have their jaws replaced. And it's just a real storm that people find themselves in that people don't understand. They don't know head and neck cancer
Right.
patients, particularly. And it's important to get the word out there so that everybody understands, this is not, we're not talking about sniffles that maybe you're worried about with some of the other vaccines. This is cancer. This is serious, people. So pay attention and please get your kids vaccinated.
Thank you. What a way to emphasize the impact of this vaccine and what happens when we don't vaccinate. So thank you all so much for being amazing panelists and presenters today. And thank you as our audience for engaging with these presenters and engaging in such a great discussion. We're going to go on and move to our closing, but to my panelists, there was another question that came through in the Q&A box. If you are able to answer that, I believe this may be directed more at Anu. Just checking that out to make sure that we are able to answer all the questions that have come through for us. But thank you. All right, so we're going to share screen again and go on to our closing, where we're going to talk a little bit more about next steps, resources, and some other educational opportunities you may want to be tuned in for. But first, we are going to start with a post-session poll. So please tell us, after today's session, or following today's presentation, what is the most important factor in encouraging on-time HPV vaccination? I'd love to know what you think now that you've sat in on this presentation. And there's a few other questions as well. Did you learn anything new today? Anything new about the current vaccination landscape or the HPV vaccine? And if so, what was new to you? We want to know. And lastly, if there is any additional content that we could provide to help assist you in your own HPV vaccination efforts, let us know that as well. I'm going to give you all a few minutes to answer those questions. Looks like 100% of responses are coming through as a strong provider recommendation. So I'm so glad that everyone's been listening and has a clear grasp on, what really makes a difference in this space. And I saw someone mention in the chat if some links could be shared. I'm not exactly sure which links you're talking about, but again, all the session materials from today, the slides, the recording, and a resource roundup are going to be shared post session. So do be on the lookout for that follow up email to let you know that everything has been updated and is ready to go. All right, we're only at about 50% participation in responding to the poll. So do continue to enter in those responses. All right, Katie, we can go ahead and close out that poll, and we're going to go ahead and finish wrapping up for today. All right, so as we wrap up the call with just a few more resources and some other things that you might want to hear, I would just like to call to your attention some related content. So the ACS National HPV Vaccination Roundtable Best Practice Task Group has developed a series of brief, easy to read summaries highlighting what's known, what's new, and what's next for key topics related to HPV. So I have pulled out a few that I found to be pretty relevant to today's topic and conversation around communication strategies for providers and increasing HPV vaccination. So follow the link to explore these evidence-based summaries. Next slide. Now, additionally, ACS's HPV vaccination communications toolkit may also be super helpful for those looking to, and seeking outreach tools, including for health plans communicating with health systems, providers and members in health systems, and providers supporting HPV vaccination efforts. So follow the link in the chat to download that as well. Next slide. And lastly, Anu shared a few statements from some leading organizations regarding the 2026 vaccination schedule changes. But many states have also released statements such as California, Illinois, Kentucky, just to name a few. This list is not inclusive, of course, and to all statements that have been made thus far. And the University of Minnesota has also released a blog post sharing that most states have rejected the U.S. HHS changes to childhood vaccination schedules. So do be sure or to be on the lookout for what your state is saying and any statements that they may be making at this time. Definitely feel free to check out that post and just stay up to date on the current trends around vaccination changes. Next slide. Now, following today's airing, as previously mentioned, all session recordings, slide decks, and resources can be found in the program Learning Materials Library. So a follow-up email will be sent letting you know that all content has been updated and uploaded. And if you have any questions or issues accessing this content, feel free to reach out to me at implementationscience@cancer.org. Next slide. Now, I would love to invite you, your colleagues, your network, pretty much anybody to register for our next sessions as we dive deeper into topics surrounding HPV vaccination and, spoiler alert, an amazing session dedicated to cancer, cervical cancer elimination. So thank you, Anu, for kind of preempting us a little bit earlier this December as this program works to begin incorporating topics from across the cancer continuum. Our next session, session 2, will be held on Thursday, April the 16th from 2 to 3 p.m. Eastern, discussing HPV vaccination QI success stories, and we really hope to see you there. Next slide. Now, if you are a rural healthcare partner, the Rural Learning Community is also launching its programming next month, March 11th, introducing new topics such as colon and cervical self-collection with more survivor stories and a dynamic curriculum. Monthly sessions are going to be taking place on Wednesdays from 2 to 3 p.m. Eastern, and registration is rolling, so do feel free to join at any time. Next slide. Now, the North Dakota State University Center for Immunization Research and Education, in partnership with Sanford Health, developed a free self-paced learning program. There are 5 one-hour modules available, which are designed for current and future healthcare professionals seeking up-to-date evidence-based education. Each module is going to include about 3 to 4 short videos covering some various vaccination topics, and participants may complete these in any combination or any order that they would like, with the option to earn free continuing medical education, so CME credit, or a certificate of completion, following the maximum flexibility to meet individual learning needs and schedules. Follow the link in the chat to learn more and explore this opportunity. Now, next slide. Now, right before it hits 3 o'clock, I would just like to leave a few action items as each of you continue your HPV efforts. Be sure to review the American Cancer Society statement on the importance of vaccination to the cancer community. We believe in science-based recommendations and continue to advocate for on-time vaccination of adolescents to improve vaccination rates and cancer outcomes. Next, prepare to celebrate the 20-year anniversary of the HPV vaccine this June by staying informed about HPV vaccination in your state, and in response to the developments from leading organizations. And of course, don't forget to register to join us for session 2, again, HPV vaccination QI success stories in April 16th. Next slide. Now, thank you so much for joining session 1 of this series, and we really look forward to seeing you again soon. We'll go ahead and stop the recording here. And for those of you who are planning to redeem credit